Hello, I'm Michel Ferrari. I'm a professor of neurology working at Leiden University Medical Center in the Netherlands. I'm particularly interested in the treatment of migraine, and I like to welcome you to this program titled Current and Future Perspectives on Migraine Prevention Therapy. I'm joined today by my friend Lars Edvinsson. He is a professor of medicine at Lund University in Sweden. The objectives of this program are really threefold. During the program, we will discuss what are the current best practices for preventing migraine attacks. How can we best identify patients who are suitable for migraine prophylaxis? And thirdly, what are the latest developments, the clinical research data on migraine prophylactic treatment? Lars, what do you think would be the main objectives of prophylactic treatment in migraine?
Well, they are quite obvious. To reduce frequency of the attacks, the severity, disability, preventing chronification, and the need of acute care medications. Well, Michel, which patients are best suited for the preventive treatments?
Well, I think most people would agree that patients who have 2 or more attacks per month are good candidates for migraine prophylactic treatment. And the reason for that is really to prevent that the attack frequency will increase further on, chronification, but also to reduce attack frequency and to reduce the severity.
Yes, of course there are a lot of drugs out there. Which treatments are the best available for prophylaxis?
Well, it's interesting. I mean, if you look at the available armamentarium for preventing migraine attacks, there are 5 or 6 different classes of treatments. For instance, beta blockers, or calcium antagonists, or serotonin antagonist, or angiotensin receptor blockers, perhaps also amitriptyline, but we really don't know how they work. They all have very different pharmacological actions, and we don't know what the common mechanism is which really is effective in preventing migraine attacks. Knowing that the current treatments have all very different mechanisms, what's your view on the likely mechanism of action for migraine prophylactic treatment?
Some of them have been suggested to act on this phenomenon, the spreading depression, and that's mainly animal data. I think many of them have difficulty in passing the blood-brain barrier, so perhaps we should think that there are perhaps 2 places they could act, both central and peripheral.
So, for instance, this drug, this ona-botulinum toxin, which has been used to treat chronic migraine, where would that work then?
Again, it's out there to be discovered, but the simplest way would be that it blocks proprioception. But of course there are also ideas that it can go via sensory fibers to act on, for example, the trigeminal system.
So basically outside the brain.
I think so.
Isn't it interesting to see that a brain disease like migraine can be treated with drugs which act outside the brain?
That's interesting, and perhaps the reason lies in what are we treating? Is it the tuner of the system that is perhaps acting on, for example, the trigeminal ganglion, that can take away pain and associated symptoms? That could fit with such a view.
So your bet would be the trigeminal ganglion?
Somewhere in the trigeminal-vascular system. In general, what are the pros and cons of the current options for treatment, Michel?
Well, I think the main problem is none of them have ever been developed for migraine. They all are drugs developed for different diseases, and as you can say, side effect of that, they also seem to prevent migraine attacks. So they are not very targeted, and they have a high risk, I would say, a high risk of side effects, which causes a poor balance compared to the efficacy.
So safety and tolerability concerns.
Absolutely, yeah, absolutely. I think that's the main disadvantage of the currently available migraine prophylactics. Yes, absolutely.
Are patients adherent to the medications?
Well, that's another disadvantage of the currently available drugs, is that you need to take them daily, and perhaps once or twice or 3 times a day. And it would be ideal if you would have a medication which you could take, let's say, once a month or once even every 3 months or so, but not with the current drugs.
What about effects of overuse of medication and involvement in headache? I mean, it's a difficult issue. I mean, shall we take the patients off the drugs when we put in a new, or what is your views on the strategy?
Well, that's an interesting question, because I think there are different views on both sides of the pond. If you look at chronic migraine, you can have chronic migraine with or without medication overuse, and many countries in Europe think that medication overuse is extremely important. So the first thing you need to do is to withdraw medication in those patients who are overusing these drugs. The problem, of course, is that will cause a major worsening of the whole clinical features. I mean, the headache will increase, the severity will increase. So that's not what most patients want. And it would be absolutely fantastic if we would have a drug which could actually make it not necessary that you first withdraw from acute medication and only then will have an efficacy. So personally, what we do now is withdrawal first,
Yeah.
and we would hope that new drugs would not make that necessary.
Yeah. No, all clinicians know that it is very difficult to get patients off the drugs once they are on an overuse situation. And in clinical trials, it is the most frequent behavior that patients are off medication before they start on a trial drug. The new CGRP antagonist, the antibody, there was one study that I participated in chronic migraine, where the patients were allowed to enter if they still were on chronic medication or not. And the interesting data was that there was good effect in both groups, and in those that had a large consumption of the chronic usual migraine drugs, there was also significant reduction in the use of these drugs. So this could be an important issue.
Oh, that would certainly be a breakthrough. If that could be confirmed in phase 3 trials, that would be a major step forward. Yeah.
Of course, we have to see what happens.
Absolutely,
Yeah.
yes. Yeah. So, Lars, you just mentioned the CGRP agents, anti-CGRP agents. But I think it's 1985 that you originally proposed that blocking CGRP might be a fantastic way of treating migraine attacks. Could you tell us a little bit about that?
Yes, of course. The whole thing started actually 83 when it was discovered that the calcitonin gene produced calcitonin gene-related peptide in neuronal tissue. So we started our project already then. What happened in early 1985 was the publication of this review. And I described there for the first time the CGRP containing nerves in cranial blood vessels, the trigeminal ganglion, and also the very strong vasomotor responses to CGRP. And I was also lucky enough to suggest that it could be involved in migraine. And 31 years later, this idea has come to some kind of fruition. I did a lot of basic research, but was joined by Peter Goldsby, and we could study a lot of different primary headache conditions. And the most exciting was the initial, where we observed that in all the migraine patients, when they had an acute attack of migraine, there was release of CGRP. After the attack, it normalized. At the same time, we studied some other molecules, and it was substance P, which was a peptide of that decade, and it had no effect. We studied VIP because of VIP of the involvement of parasympathetics, and NPY as involvement of sympathetic fibers. No change. And the important issue in this work was actually that we compared blood sample from the jugular vein and cubital fossa, and that we saw no signal when we took peripheral blood samples. So that was a kind of a very important study. This was followed by a long series of different kinds of primary headache conditions, and in other conditions like cluster headache, chronic paroxysmal headache, all of these patients had CGRP release, which normalized, for example, in cluster headache after treatment with triptans, and as did in migraine patients. Because of the phenotype in cluster headache and chronic paroxysmal headache, that is reddening of the eye, nasal congestion, rhinorrhea, signs of parasympathetic activation, these patients had also release of parasympathetic VIP. So it fits very nicely with the neurology. The story continued. I did a lot of basic research, and a major breakthrough came when the CGRP receptor was described, because it turned out to be a G protein coupled receptor of the B type. And that means that it contains one aspect, which is a 7-TM receptor, the calcitonin-like receptor. But for it to work, we need to have an associated receptor amplifying peptide called RAMP. When these two meet during stimulation by CGRP, the receptor is activated, and the G protein and the intercellular processes goes on.
And these receptors are in the important regions for migraine pathophysiology.
Oh yes, we have in subsequent studies shown that they are, for example, in the meninges, in the trigeminal ganglion, and in other pain pathways belonging to this system, in the trigeminal nucleus caudalis, in other parts of the brainstem. This led companies to start to produce CGRP blockers, and they are called gepants. And for me, it was very rewarding that these trials, they were all positive in acute migraine attacks, both to produce migraine relief at 2 hours, but also pain-free. And it was also exciting to note that they resulted in sustained pain-free at 24 hours. And that was significantly better than the triptans. So that was kind of disappointing when chronic administration of the gepants resulted in liver enzyme activation, and the program was halted. This was followed now recently with a group of other companies that have antibodies acting either to take up circulating CGRP, that's 3 of the companies, and 1 company acting to block the CGRP receptor. And these have been presented, their results from the phase 2b studies. And again, to my astonishment, all these studies were shown a significantly better effect compared to placebo.
They all are statistically significantly better than placebo.
Yes.
And we need now to see how that pans out in the phase 3 trials.
Yes, and as you know, all these companies, they are in phase 3, both in frequent episodic migraine and in chronic migraine. So maybe we will hear some news next year on these results.
Yeah, would be fantastic. If I look at the data, I mean, one of the surprising things I noticed is that it seems that there are either responders or there are non-responders. So there is a group of patients who respond fantastically, and others they don't, or only moderately. So what's your take on that?
This is a great question, Michel. I mean, the little information I have is that, as you say, one group responds fabulously and they even get rid of their migraine. There's a group that responds with less frequent attacks and less severity, and of course there's a group that show no effect. Could it be that there, of course, could be other molecules involved? And we know that in the trigeminal system there are other molecules of interest. Of course, it opens up for future research. One issue you also might be thinking of is how could these antibodies act and in what way?
You are a vascular person by heart, so you don't think it works on the blood vessels.
All right, I think it works where they are released onto the receptor. And CGRP, I mean, 3 of the companies have antibodies towards CGRP, meaning that the antibodies get the CGRP out of the equation, that there would be less in the transmission phase. And the 4th company have a blocker to block the transmission between the nerve and the postsynaptic receptor. The role of the smooth muscle CGRP receptors in the vasculature, it's I mean, it could be an additive thing. And perhaps if you think about the triptans, we have also moved there from being a vasoconstrictor as a main mechanism to something that inhibits the release of CGRP. So I mean, the science evolves.
So it took 35 years to
Right.
move away from the blood vessels.
Absolutely.
Yeah. You think that there are any disadvantages? I mean, basically you're wiping out the whole CGRP system, you're blocking everything, and CGRP, there should be a reason for having CGRP. Aren't you afraid for major side effects?
Absolutely. I mean, we have thought of this also during these 30 years. And one issue was the possibility that CGRP acts as a protective agent in conjunction with different kinds of stroke. And we looked into subarachnoid hemorrhage, and of course CGRP can have a role there. So one could have this as a problem. There are, when we talked about the gepants, there was a discussion if it could modify or worsen the effect when you have an acute myocardial infarction. And at that time, the company doing the gepants, they did experiments in coronary ischemic conditions, and they didn't see any deterioration using the gepants.
Lars, I mean, the good thing is that in all the trials so far, we haven't seen any major cardiovascular or cerebrovascular accidents.
No.
So that's good. But yes, we really need to do. I think you did some studies already, isn't it?
We did in subarachnoid hemorrhage, in a little in animals, but also quite a series in patients. And the interesting bit was actually in the patients. It was patients with vasospasm, severe vasospasm after subarachnoid hemorrhage, where we infused CGRP and we could reverse the vasospasm. So it could be used as a remedy. On the other hand, we have never tried a CGRP blocker in any of our stroke or coronary heart infarction models. And that is lacking information in the literature.
So you would suggest that people need to start doing these type of studies?
Yes. I think that.
Yeah, I totally agree.
Yeah.
I totally agree. Yeah,
Right. There's another issue which also has been discussed, Michel. That is, we both believe migraine, primary headaches, it's a brain disease. But the take on the action of these drugs, I mean, triptans, gepants, antibodies suggest that they don't pass the blood-brain barrier. And of course, that is also something we need to understand better in the future.
Absolutely. The side of action is crucial to know.
Yeah. So in my kind of world, we have tried to find out if these agents pass the blood-brain barrier, and I don't think they do. We have had models to induce inflammation in the terminal vascular system, and we don't see a quantitative opening of the barrier, which agrees with current available results in the literature. So therefore I've been thinking that perhaps the trigeminal ganglion can be, so to say, the tuner in the system, and it is accessible to all these anti-migraine drugs because it has no blood-brain barrier.
How can we prove that is the side of action?
That is another kind of research line we are trying to start up right now, because with histochemistry we can show that the receptors are, and of course CGRP, exist in different parts of the trigeminal ganglion. So the question is, can we find out if these receptors are functional in the ganglion? So that's one kind of line. Yeah, regarding this, we did discuss a little bit about the concerns of the antibodies. And the personal concern is actually, as a doctor in internal medicine, antibodies, this is yet another antibody we give to patients, and they already have TNF-alpha antibodies or something else. Can they interact in some way? Or so what's your take on that, Michel?
Those antibodies are interfering with the immunological system. I think the beauty of this one is it's basically a very targeted blocking agent. I mean, it blocks the receptor, or it blocks or takes away the peptide itself. So, I'm looking forward to the results, but we really need to wait for the phase 3 trials.
Yeah, now we have discussed about CGRP, my favorite molecule, but we know both that there are other ways that are under discussion in this field, and neuromodulation is one, for example.
Oh yeah, I think that we can learn a lot about how neuromodulation is actually able also to prevent migraine attacks or attacks of other types of headaches, such as cluster headache. So that's another a very nice area to study.
What are the most important messages for clinicians and patients?
I think that physicians should be aware of that patients who have 2 or more migraine attacks per month are candidates for migraine prophylactic treatments. The problem with the currently available agents is that they might be effective, but they also are associated with a relatively high risk of side effects. So the balance between efficacy and side effect profile is not optimal. And what we really need is new prophylactic agents which are safe, well tolerated, and of course also effective. And, there is hope. There's hope for the future. Well, thank you, Lars. Thank you. I really would like to thank Lars for his insightful opinions about the future of migraine prophylaxis. And thank you all for viewing this program.